All right, good evening, everyone. Thank you for joining us. My name is Melanie Ionase, and I'm a physician relations specialist here at Rothman. Tonight's webinar is with Dr. Chris Kepler, spine surgeon here at Rothman. His office locations are Washington Township, Marlton, and Center City. The topic that he'll be covering this evening is lumbar spinal stenosis, diagnosis, and treatment options. In this lecture, he'll be exploring the causes, symptoms, and the latest treatment options, including both non-surgical and surgical approaches. Whether you're a patient, caregiver, or simply curious, this session offers valuable insights. Just a few quick notes that this is being recorded, so you will get this in your email in about 5 to 7 business days. And also there's a Q&A question box on the bottom of your screen, so please feel free to ask questions throughout the lecture, and we will be able to get to as many as we can before the lecture is over. So thanks again, and Dr. Kepler, we welcome you, and thank you for your time this evening.
Thanks so much, Melanie. Welcome, everybody. This is a topic that, unfortunately, a large percentage of the United States population will be interested at some point or other in their life. And, this is sort of touching the tip of the iceberg. I think that it often, the presentation brings up more questions than it answers, which, in some ways is one of the points. And also, that's how people make this relevant to their life. So if you have specific questions about one aspect of it or treatment or something that doesn't make sense, put it in the chat, and then we will get to as many questions as we can at the end, and usually we have plenty of time. So this is what we're going to try to cover tonight. How common is spinal stenosis? What exactly that means? There's a couple different principal types of it, and I'll try to explain this to the best of my abilities. Talk about the signs of it, the symptoms that come from spinal stenosis, and then duck into treatment of it and how things turn out. And then one thing that I always want to touch base, because it is an adjacent topic, but is something that's important for people to understand, is where is spinal fusion and screws and rods fits into this. And the punchline there is often it doesn't. And I think that's really important, because that is something which, rightly so, should raise people's blood pressure a little bit, because it does entail a bigger surgery, and often the treatment of spinal stenosis is totally unnecessary. All right, so spinal stenosis is the most common reason for lumbar surgery in patients 65 and older. But by the time it's all said and done, 10% of people in the US will have lumbar spinal stenosis, and 10% of people will experience symptomatic lumbar stenosis in their life. 1 in 1,000 people has had surgery for it. So this is a huge problem, with an annual expense of over $1 billion. And if you look at the other sort of related association or related symptoms and problems people run into, that number is much bigger than $1 billion. It's certainly the most common reason that we do spinal surgery at Rothman Institute. So what does it mean? What does spinal stenosis mean? And stenosis, the term, just means a narrowing. And you hear people talk about aortic stenosis, where the aorta is narrowed. There's a lot of different types of it in the body. But in the spine, what it refers to is symptoms of pain, weakness, or sensory changes due to nerve compression. So in as much as stenosis means narrowing, it means narrowing around one of the pathways that the nerves travel through the lumbar or low back spine. The compression of the nerves can be from arthritic changes. That means bone spurs, that means overgrown ligaments between vertebrae. It sometimes can be to slippage between the vertebrae. And what that means essentially is that as two vertebrae are not lined up with each other the way they should be, you have less common overlapping space between them, and the nerves can get pinched on account of the fact that the vertebrae are not in line with each other. Another, kind of similar cause, but a little bit different than the arthritic changes, is a disc herniation. Recognizing that that's a condition that's more common in people who do not have arthritic changes and don't have as much degeneration in their spine. So in general, that often would be a younger population. And you can see on the right, the pictures on the right at the top, the main thing on this particular image to draw your attention to is in this central area, you have a white oval. And then within that white oval, and here it looks like a gray oval, but what that gray oval is a bunch of little dots, which are the actual individual nerves. The white is spinal fluid that your brain makes and travels within the sac that carries the nerves through the spine. In this setting, it's really just important as a marker for space around the nerves. If you look at the bottom level, this is again in a similar cut, all the white's gone. You can still see the gray oval, which again is a collection of nerve roots, but this area is tight enough that all the spinal fluid has been squeezed out, and it's on the basis of a disc bulge, which is where my cursor is on top of the area where you see the nerves. This triangular shape is probably a piece of bone that comes off the joint that connects the vertebra that's pinching the sac. Same on the other side. And so this would be an example of a pretty arthritic spinal canal that's causing compression of the nerves. So I just showed you one, but we'll be a little bit more clear on what the types of spinal stenosis. And speaking generally, there are two. Central stenosis is the exact same picture I just showed, which shows the loss of the white oval with pressure on the nerves. Because the nerves travel from top in the brain to the legs down below, this could affect any nerve below the level where it happens. And so we get a lot of the information on where the problem is and what's likely to be causing symptoms people get based on the part of the leg or the muscle in the leg that's affected with the stenosis. Now, and that's called central stenosis. It's sort of logical in the center part of the vertebra. Foraminal stenosis affects the foramen or the nerve tunnels where the nerves leave the spine. Now, this one, as opposed to pinching the whole sac where any of the nerves which are leaving below that level could theoretically be affected, this only affects a single nerve, and it's the nerve that happens to be leaving on that side at that level. And so just before we go to the next slide, which has a little bit more information on what that means, what I want to draw your attention to is right side of the screen on the top picture, which is the left side of the body. By convention on an MRI, the sides are flipped. And so this lighter gray area here with this gray dot in the middle is fat around the exiting nerve. The darker gray dot is the nerve that's leaving to the left side. On the picture below, you can see in the middle of this red oval, this hemicircle of black is a bulge from the disc, and the nerve is you can see a little bit faint, but there's a darker gray area in the middle there, and that's the nerve getting pinched as it's trying to leave the spine. You don't see this big surrounding lighter gray area, which again is the fat that surrounds nerves normally in the body. And so in this case, whatever level, let's say this is L3-4, this would be the right side of the screen, left side of the body. The left L3 nerve would be getting pinched. So what are the signs and symptoms? And we'll use that left L3 nerve again as an example in a couple slides. So symptoms vary widely. And one thing that's always really important for people to understand is that having spinal stenosis on an MRI doesn't mean you need an operation. In fact, far from it. Many people have stenosis and don't know it, meaning they don't have pain in the butt, they don't have pain in the legs or weakness in the legs. And if that's the case, this becomes just an incidental finding, really. And you steer people away from, doing anything about it. But as I mentioned before, the level of the stenosis, the part of the spine, whether it's the upper lumbar spine or the lower lumbar spine, dramatically changes the flavor, the specifics of what the symptoms are that's associated with that. So in general, there's a couple main symptoms we tend to see. Radiculopathy is the general term for nerve-related problems, and this could be leg pain, this could be leg weakness, and it should have in there sensory changes, numbness, tingling, and a part of the leg is based on what nerve is affected. Sciatica is not, I guess it's a medical term. It's sort of more of a sort of commonly used term that means radiculopathy, so nerve pain typically or weakness that goes down the back of the thigh and the back of the leg, and so it's a nerve that's associated with the sciatic. It's a problem associated with the sciatic nerve, which is made up of the L5 and the S1 nerves that join together after they've left the spine. The classic pattern is that leg pain gets worse with prolonged standing or walking a distance. People find often if they lean forward or if they, are in a grocery store and they can lean on a shopping cart, or if they take a break and sit down, it relatively quickly will ease the pain. They can get up and go again, but the same thing is likely to happen. And so, people with spinal stenosis are the ones who are always looking for a bench when they're walking. And so, this is a picture that shows a distribution of the different nerves and what part of the body they go to. And this we use very, very heavily on a daily basis when we're in the office trying to match up findings on MRI with people's symptoms. For instance, the example I used a couple slides ago of the L3 nerve getting pinched, that was the left side, this is the right leg, but you can see the L3 nerve starts up on the outside of the hip by like the pocket of your jeans and spreads across the front of the thigh to the inner thigh. Whereas the S1 nerve is like a line straight down the back of your leg. This is a picture of the foot from the, or the leg from the back. This only shows the, what we call dermatomes, which is the part of the skin that gets innervation and would have pain or numbness depending on what nerve's involved. There's a corresponding map that's a little bit more complicated because the different lumbar levels often overlap in terms of what muscles they control. But there's a map that shows which muscles go with which nerves. And so that would be, help us understand patterns of weakness. The pain and the numbness symptoms, which are, different sensations, follow the same pattern though. So other symptoms that can be associated with spinal stenosis, and this is thankfully is very rare, urinary changes or bowel changes, incontinence or urinary retention, or sometimes constipation, although that's highly unlikely. That usually is related to dietary problems or gastrointestinal problems. But when you have severe stenosis, it can affect bowel and bladder function. Doesn't happen a lot. One thing there's a near consensus on, and this is not quite true, but it's close to true, is that most spine surgeons do not think that spinal stenosis is a common cause of back pain. And this is where we run into, not difficulties, but a misunderstanding with people often who come in with a report or an MRI that says they have spinal stenosis, but the main symptom they have is back pain. As I mentioned earlier, a lot of the arthritic degenerative changes which cause nerves to get pinched and can cause stenosis or pain running in the butt and down the legs are arthritic changes, and they occur in the setting of disc collapse and arthritis in the joints that connect the vertebrae together. So the same underlying processes can cause back pain on an arthritic basis, or spinal stenosis and leg symptoms from pinching nerves. But the two are not quite the same, and taking away the bone spurs and taking away the overgrown ligament, which are features of arthritis, does not commonly lead to improvement in low back pain. And so, that's one of the big challenges we face, is in people's mind disentangling the presence of back pain from spinal stenosis. Okay, so what happens with spinal stenosis? And one thing that I want to reiterate, which I said a couple slides ago, is what doesn't happen is that most people will not ever develop difficulty with bowel or bladder control. Okay, most people will also not become weak to the point that they lose the ability to walk or something like that. That is a common fear. There once in a while, non-operative or operative spine physicians, maybe not necessarily purposely, but purposely or non-purposely mislead people into thinking that's likely. It's very, very unlikely. And if you look, this is the natural history is the term that we use to describe sort of what happens if you don't do anything, you don't intervene. And in a 4-year study, and this has been replicated a number of times, but this is a particularly important one in the sort of the history of understanding spinal stenosis. Overall, this is sort of people's general opinion of how they are. Over 4 years, 15% thought they're better, 15% thought they were worse, 70% thought they're about the same of people with spinal stenosis. Same for pain levels. Some people got worse, a little bit more got better. Most people are the same. And walking, 42% of people get better. So I think the take home from here isn't necessarily, this doesn't describe features of the people that got better or worse or the same. So, in the context of the discussion we're having now, is not useful for helping identify on an individual person's basis which one you're going to be in. But I think the take home is people aren't falling off a cliff. And given the fact that most people, probably the biggest group of these are people who are about the same, decision making on what to do with spinal stenosis should be made on the basis of the quality of your life when we're talking about it, not out of fear that if you don't do it, something's going to happen down the road. In particular, because again, not to beat a dead horse, but to look at this fourth bullet point, which is nobody got paralyzed in this study from not doing anything. one or two people out of hundreds and hundreds had difficulty with bowel and bladder function. All right, let's talk a little bit about treatment and results. Every single person I see, if they haven't already been through this, will begin with non-surgical treatment. With the exception being rare situations of people who come in with substantial weakness, or if they really are losing control of bowel or bladder function. As we saw in the last slide, sometimes time alone is enough to ease the symptom. People come in a bit of a bad flare, riding it out a little bit often leads to 20-30% of people feeling better. Anti-inflammatory medications is the mainstay of most arthritic conditions, including spinal stenosis. This has the advantage in a population that commonly has a certain degree of back pain in treating that as well. There are two nerve pain medications on the U.S. market, Lyrica or pregabalin, or Neurontin. The generic name is gabapentin. These are really commonly used. I've given them out thousands and thousands of times over the years. In general, they have a very favorable side effect profile. The main thing that I hear not consistently, but when you hear someone with side effect from it, is that gabapentin makes my estimate like 15 or 20% of the people kind of tired or sleepy, in which case it's not often a very good choice. Physical therapy is more of a treatment for low back pain and arthritic changes than it is for leg pain and sort of sciatica or radiculopathy. We still use epidural steroid injections. I would say the one change in the last 10 or 15 years as far as the use of injections, well, there are two maybe. One is that everybody used to get in, and if you got one, you got three, meaning a series of three. Sort of more recent evidence has shown that that isn't a real good way to do it. It doesn't make sense that the third one's not necessarily any better than the second or the first if they're not working. The other thing is that for people who have really severe central stenosis, where the central tunnel is blocked off, epidural injections may delay the need for an operation, but have not been shown in larger scale studies to actually lead to surgical avoidance, meaning like it isn't going to save the day. But particularly for people who have a certain reason that they can't fix something just yet, or particularly if they have spinal stenosis due to disc herniation, epidural injections are still used widely. And for the disc herniations, the reason for that is that is a problem that very commonly will come and go on its own. And so there's a bigger benefit in those people to just riding it out and seeing if you can't wait for the body to take care of the problem on its own. Whereas when you and this is probably the reason injections don't work well for central stenosis, is that if you have a bone spur pinch in your nerves, that's not going away. And even if you can temporarily decrease inflammation, it's very likely to rear its head again. I have no objection whatsoever to alternative therapies, whether this be seeing a chiropractor, acupuncture, prolotherapy, you name it. I've encouraged people to try it if there's a chance it's going to save you from getting an operation. One thing that's a little bit difficult on the Jersey side of things, I'm mostly in Jersey, although I go to Center City as well, is that on the Pennsylvania side, we actually have one of the non-surgical spine providers who also is a chiropractor. Who also does acupuncture. And that's always been a really nice avenue of people to explore. On the Jersey side, we do not have someone within Rothman Institute who does that. So you're a little bit more on your own. In general, when you have a flare of leg pain or back pain, you want to avoid bed rest. And, with rare exceptions, we want to avoid using narcotics in this setting. Narcotics in particular, you don't see it on my list. In the discussion of spinal stenosis, really are not an effective treatment. And the reason for that is that, like narcotics, you're going to be break your ankle, or if you have an operation and you have a muscular pain afterwards or bone pain. Nerve pain is processed in a different part of the brain and not by narcotic receptors. And so or not an opiate dependent pathways. And so narcotics really don't work well for buttock and leg pain associated with spinal stenosis. So if all that fails and people are still suffering with pain in the butt and down the legs, that's when you would consider an operation. And like I mentioned before, one of the great things about the treatment of spinal stenosis from a surgical standpoint is that often it doesn't require anything more than a clean out job, meaning opening that canal where the nerves are pinched, taking away bone spurs, taking away overgrown ligament, or disc herniations to free the nerve up. That has a success rate. Well, we can get to that in a little bit. So laminectomy is the most common operation performed in the United States for spinal stenosis. It's the most common spine surgery performed in the United States. And the lamina, where you can see where my cursor is this back part of this spinal canal. Now, sticking out of the middle of it is the spinous process, which you can see here. And that's when you put your hand on your back and feel for the bumps. You're feeling the spinous processes, which are attached to the back of the lamina. And so taking out the laminectomy is taking out the lamina, which basically allows you to take this tunnel where the nerves are traveling and turn it into a trough so they can have as much room as they need. Once you're in there, you take the bone spurs out, you take the overgrown ligament out, all that stuff. So contrasting, so people who have a laminectomy, I think is in my practice is a 90 or 95% success rate for the butt and the legs. Spinal stenosis does not cause back pain. Treatment of spinal stenosis will not make your belt line or above pain better. In surgeries where we can get away without having to put any metal in there, which is the majority of the time for treatment of spinal stenosis, is a very low infection rate, way under 1%, probably a quarter of a percent. The most common complication, but the least consequential, is getting getting a spinal fluid leak. And so when you look at this picture on the right, this cartoon, the yellow or green, I'm sort of colorblind, so I can't tell for sure which that is, but represents the sac that carries the nerves through the spine. And as I mentioned before, within that oval sac, the white on the MRI is spinal fluid. That's a thin-walled structure, and about 1 out of 20 surgeries, you get like a nick or a hole in it. It's really just from manipulating it because it's sort of a flimsy thing. It's something that's fixed during the surgery. There's no real long-term consequences to that, but it can, the first night out of the gates, for the first like 5 or 6 hours until your brain can make more spinal fluid and fill the sac up again, you can get a spinal headache. The most severe complication rather of any type of lumbar surgery is a chance of getting a nerve root injury, which is typically like a stretch injury when you're manipulating the nerve root in the sac. That would lead to weakness in one leg and one muscle group, but usually gets better on its own. And usually this is either go home the same day if it's one level or 2 levels, one night at the most, typically two. This is probably a 6-week all in recovery. I thought I talked about laminotomy. Sorry, I'm just cheating ahead real quick. No, okay. So I thought there was another slide here. So laminotomy, which you can see on this top bullet point on the right, is basically keeping the one side intact, leaving the midline, the spinous processes bump, and you'd sneak in on the side and only take away bone on one half of the back of the vertebra. And that would be more likely if you had like a disc herniation off to the side that's pinching just one side. It's a goal. The goal of that is to sort of spare some of the release of the muscle from the back of the vertebra so that it doesn't hurt as much and it's a faster recovery. If it's a single-sided symptom, that may be an option. The recovery is not that much shorter, but it's a somewhat easier recovery. All right, sorry, catch up to where I was. So this is a device that has a very checkered history, and this is like the phoenix. This is rose from the ashes, like 5 or 6 iterations. X-stop, you can see on the X-ray on the right, is one of the first ones that was out there. Was taken off the market for not working. There's a number of newer visions of this that are basically the same. It's something you jam between the two fingers, the spinous processes in the back. And the idea is it's supposed to spread the vertebra apart a little bit to make more room, particularly for the nerve tunnels, because as you have a collapsing disc in the front, that nerve tunnel gets shorter. So the idea is you jack it open again and the nerve's not pinched. They don't work real well. One thing that I would sort of caution against is a lot of times these are being done like in surgical centers by pain management doctors who went to like a weekend course. But the bigger thing, because anybody could do it, they don't work that well. And what you see over and over again, looking through this same theme that's played out a number of times over the last 15 or 20 years with sort of a new version of X-stop every 4 or 5 years, is that they work initially because they do spread the vertebra apart. Eventually, you just going about your business and, moving, bending, twisting, that piece of metal will cut through the bone and the vertebra gets closer together, and then you end up with this loose piece of junk in your back that we got to go and take out and fix. So there may be some situations where people who are not healthy enough for general anesthesia or have, particular types of pressure on the nerves that this might be an option for. But in general, I would really shy away, particularly given the fact that the tried and true, single level laminectomy, which is what this would treat, is so successful and also has much more durability in terms of the results of it, meaning that it'll last a lot longer than this thing that usually will cut through. Um, This is SPORT is an acronym, Spine Patient Outcome Research Trial, sort of a dumb name, but was the biggest, widest ranging study about spine surgery in the United States. That was funded by the federal government. And of the different groups, they studied one with fusion, one with just discectomies, one for people who had spinal stenosis. People who had surgery compared to people who just sort of gutted it out had less pain overall better physical functioning, which isn't to say that people who didn't have surgery did terrible. They didn't. They had small improvements in most of the outcomes measure, pain in the back, pain in the leg, ability to walk. Nobody in this huge study, it's like thousands of patients, lost the ability to walk or got caught Aquinas syndrome, which is a urinary and bowel function losses. So, again, it isn't to say everybody needs an operation, but in general, when we've taken a step back and looked at this in a comprehensive manner, people who have severe central stenosis do very well with surgery. So what about fusion? This is like, in a lot of ways, fusion is the boogeyman in the spine world. And like with good reason, there's not the big in the spine world, usually the smallest operation you can do is the best one, all things equal. And so fusion means in this day and age means putting in screws and rods and bone graft. And before the instrumentation systems, the screws and rods were invented. It just was bone graft, and you wear a body cast. No one does that anymore, but it still is bone grafting accompanied by some sort of metal fixation. These are the things that often require fusion when they're treated. Spondylolisthesis, which is a mouthful, and what it means is, if you look in the upper right, that these two vertebrae, L4 and L5, are not lined up. If that person at that level gets spinal stenosis, I can't go and take away bone from the back of these vertebrae because it'll make the shift worse. And so with pre-existing instability, once in a while there's a time we can cut corners, but in general with pre-existing instability and spinal stenosis, you end up getting stuck locking things together with screws and rods. Scoliosis, and this is a deformity correction. That thing's not going to stay, it's not going to stay straight on its own, and so you need to do something to keep it straight if that's the purpose of the surgery. Sometimes with recurrent disc herniations, this is a side view where you can see this big, sort of diamond-shaped piece of disc spitting out from the back of L5S1 and is pinching the nerves back there. The common practice in the United States, if you get a disc herniation once, you go and you take it out. You get it back at the same spot, you go in and you take it out. You get it a third time in the same spot, and you can't just keep going and taking it out. But at some point, it's like gets a little bit ridiculous, and the person in the meantime just keeps having surgery after surgery. And so, doing a fusion in that setting will shut it down, will stop it from reherniating again. And so that's not as common, but that's a situation where sometimes you need a fusion. If you're treating trauma, someone rolls their motorcycle and they break their back, and the two pieces aren't in line with each other. That's something that has to be held together with a fusion. Or in the setting of treating tumors that have destabilized the spine, you buy back the stability for the spine with lumbar fusion. Spinal stenosis is not on the list, right? Pure spinal stenosis, and that's because you don't need to do a fusion for the vast majority of people with spinal stenosis. And that, I thought it was a little longer, but that's the end of the presentation. So we will stop there. And Melanie, do you want to take over as far as questions, or
Sure. Can you see the question as well?
I think I got to get out of this screen. Let me see if I can exit the presentation at least. Okay. Maybe I can't.
Okay.
Oh, in the chat. Is that right? Okay.
It's on the Q&A on the bottom. If you scroll down to the bottom,
Okay,
there's the
great.
Q&A, and you can just
All right.
scroll through, see what you want to answer, and we'll just go from there.
Moderate stenosis. Do you want me to read the names? Probably not. Maybe
Yeah,
I'll
just
just read
yeah,
the
read
questions.
the
Moderate
question.
stenosis at L5S1. All of a sudden, for the past month, I have severe pain in the left leg and limp. I've had to walk more than a few blocks. My current doctor is thinking injection may help, but they have never had in the past. I have a 2 month wait for it. I assume that means to get the injection. Um, so the reality is stenosis and nerve compression is sort of a clinical situation has a threshold effect. And what I mean by that is once you get to moderate stenosis, that means like the nerve's compressed. There's no real telling how bad your symptoms are going to be. And so moderate an MRI where you look at it and says moderate stenosis and you think your pain's severe, it doesn't mean something's different or your pain's not severe. It's probably well explained by the stenosis. Someone who's had multiple injections without really making any hay, there's no harm in injection. There's no complications that come from injection, but it's not real likely that all of a sudden it's going to save the day when it hasn't in the past. There's again that whole laundry list of options is in play here. Anti-inflammatory is one of the nerve pain medications. Trying an injection again. If a wait of 2 months to get injection is a long time. I know that there was a few patients I saw today who had leg pain, but just weren't at the point where I thought that they needed a surgery. And I sent them to get injections, which I don't do myself, but we sign up with our non-surgical partners, and they got them within a week and a half or something like that. So that may be an indication to go someplace that is a little bit has a higher through capacity and can get that thing done faster. But again, if you've done it multiple times in the past, it didn't work. It matches up with your symptoms. You also may be a very good surgical candidate because it sounds like this is functionally really limiting to you because it starts after just a couple blocks. All right, I'll go to the next one. I was a distance runner and was diagnosed with spinal stenosis a few years ago due to arthritis. I have MS and past surgeries and other things have caused me to freeze. Can you recommend the best non-surgical option? So yeah, MS is a tricky thing to manage with surgery because and I think what you mean is it flared the MS. And any stress to the body can do that. Certainly, generally anesthesia and an operation on your back is, sort of that raises that possibility. Um, this is a situation like unfortunately, there's no like free lunch for arthritis because, like I mentioned before, although disc herniations often come and go, arthritic changes often don't. I mean, this is where you would hope that you're in the population of people, which is real, who have a great result from something like an epidural injection. I would certainly go at the bottom of that list, aside from the medications, but try to see like an acupuncturist or chiropractor, and sometimes that keeps people going for years. Um, the other thing is that in people who have challenging medical problems that are not directly related to the spine, sometimes coordinating care with, sort of like an IVIG infusion through a neurologist that manages your MS can help you skate through something like that without triggering the big flare that, kept you at bay first. But I would do everything under the sun to avoid an operation just because MS is unforgiving disease and you can't always predict when something like that's going to happen. Um, I have bad discogenic pain with multiple annular tears. So that's tears in the back of the disc. MRI though shows a relatively healthy 54-year-old spine, no stenosis. How can you manage your pain? PT, epidural injections, chiropractor has not helped. So, it's more of a trial and error type thing because we are not great in many cases at figuring out at first pass where low back pain comes from it. And so For instance, epidural injection, though, you wouldn't expect that to help. Epidural injections is a treatment for leg pain, and you said you don't have stenosis and mostly have back pain. So that wouldn't, it's not surprised that didn't help you. There's a different type of injection called facet injections, which is the facet is the name of the joints that connect the vertebrae together. That is intended to treat back pain. There's another similar pathway where instead of getting a steroid injection into the joint, you'd get a local anesthetic injection in the joint, which is only supposed to help for a brief period, but that injection is used as an indicator as to whether or not you'd be a candidate for a treatment called a radiofrequency ablation, which is where you basically burn the nerves coming off the arthritic joints, and it can give a lot longer term lasting relief.
Which is one of the questions, Dr. Kepler. So,
Okay, gotcha. So yeah, so we'll get to that. One more thing, which I think is really exciting, and it's not necessarily something that was not something that I do, but there's a treatment called Intercept, Intercept, which is a treatment for discogenic low back pain. And it basically is like it's sort of like a burning the nerves concept, but it happens at the end plates within the bone immediately adjacent to the discs. It has a pretty successful track record. We've had a number of the non-surgical spine providers start doing this in the last couple years. And one thing that was very encouraging is because whenever anything's new in the medical world, you always got to be a little suspicious of the literature that gets published on it because by and large, it's supported by the companies that are making whatever the device is, and they have a conflict of interest to report good results. But the non-surgical spine docs within Rothman who have started doing this have sort of pooled their data and have similarly good results to the industry funded studies, and our guys don't have any conflict of interest with this. So it does seem like that may be an option as an additional treatment for discogenic pain. And the nice thing about something like that is like it's not taking a pill every day. It's something that is pretty long lasting, and so you do it once and then you reap the benefits for some period of time afterwards. All right, I'm going to keep moving down. All right, my body's not getting better. I've had injections which help, but my doctor said he wouldn't do surgery because I have more pain in my back. However, it would help my legs and butt pain. So this is a tricky spot, and this is the way I think about this because he's right. Spine surgery to treat low back pain is not that successful, and we really shy away from it because of that. But that isn't to say that even if it's not the main thing that's bothering you, that if you didn't have the pain in your buttock or you didn't have the pain in your leg, that you wouldn't be better off than you are now, even if it's not perfect. And so what I always ask people is making the judgment on whether you should treat spinal stenosis in the setting of back pain is, would you be happy with undergoing a surgery with a recovery period of, let's say, 2 months, if the only thing that got better was the butt and the leg? If that's not enough, then your doc's right. You shouldn't do it. If that, again, you wouldn't be perfect, but if that would be enough to motivate you to do it, then you should, because the success rates for the buttock and the leg, again, I know I'm saying that a lot, but the success rates for the buttock and leg are very high. And so that's the frame of mind that I think people should make that decision within. How would you recommend chiropractic adjustments as a form of treatment? Or would I recommend? Sorry. Yeah, definitely. There's, other than very, very rare exceptions when someone's got something bad going on in their neck and no one knows about it and you crack your neck and something bad happens. For the treatment of low back problems, I don't think there's any risk of seeing a chiropractor. And it's sort of like, in my mind, it's sort of along the spectrum of physical therapy in the sense that it's a physical form of treatment that uses like stretching and strengthening. And sometimes, a lot of times, the bigger chiropractic practices now have have formal physical therapy rolled into the whole thing. So I would never recommend against someone trying it if they have the motivation. I think the way you think about it is not changing your body on the inside. And so the way to evaluate whether it's worthwhile or whether you should keep seeing chiropractor is if whatever you sort of pay to get in the door is worth it from the standpoint of how you feel afterwards. You're not getting some future benefit. It's really meant to treat current symptoms. But I don't have any objection to that. I almost wish we had an in-house person to recommend, but we don't. Nerve ablation. So the reason nerve ablation was not on that list, nerve ablation is a treatment for back pain. You can't ablate you can't ablate the nerves that are pinched from spinal stenosis because those are the ones that control your leg function. So if you went in and burned the L3 nerve, your left quadricep muscle would never work and you'd never go upstairs again. So that's not a choice. Nerve ablation is done to treat the little sensory nerves that come off the joints that connect the vertebrae together. Those joints, are the telephone line to your brain that say, my back hurts down here. And so it's not included in this talk because it's not a treatment for spinal stenosis because spinal stenosis doesn't cause back pain. All right. Why don't you recommend back bed rest? Because it creates an inflammatory and muscular cycle of death. I'm just kidding. Not cycle of death, but the muscles shorten when you don't use them. It creates a tendency to cause more muscle spasm. You have to get up and move those muscles, or you're going to get stuck in a cycle where they're still tight. Um, Muscles do not spasm to aggravate nerve pain. You can have nerve pain and you can have muscle spasm. Those aren't the same. We're talking about the muscles in your back. The nerves don't travel through them. Nerves leave your spine through the front into the back of your pelvis. And so the muscles on either side of your back getting tight has nothing directly to do with nerve pain. They could come at the same time. And a lot of times when people have bad nerve pain, one of the body's responses, natural responses, is to try to splint the spine by tightening up the muscles. But those aren't coming together because one's causing the other. They just happen to come together in the same kind of condition. Nerve ablation definition. So it's a needle-based procedure, not a surgery, it's procedure. So it's done just with a stick. It's a thick needle. The tip of it has a probe in it basically that can be heated up or use radio frequency to burn the nerves. And so if you get an injection into the joints at one level and it gives you good temporary relief and you do it again, the same thing happens, then we say that level is a good candidate for radiofrequency ablation. I don't do either. But the non-surgical spine docs do this. They would bring you in, lay you on the table, probably dope you up a little bit because I think it hurts a little bit more than a regular injection. Put that needle right on the joint and turn it on and kind of move in a circular motion around it and burn the nerves that come off it. I think that the numbers of response rates, meaning like you get somewhat better after that, are something like 70 or 75% for people who respond to the injections as a qualifying diagnostic test. Cons that it doesn't work. Pros is that people who have really good response from that can have like 12 or 18 months of improved pain. The nerves can grow back, but you also can do it again. All right, let's see. Keep moving. All right. You spoke about laminectomy, a spondylolisthesis, terrible pain down the legs. I need an A-lift or a T-lift. Is there a minimally invasive procedure? So mild procedures and Minuteman, I don't know what that is. So mild procedure probably should never be done. The success rates for that are incredibly low. It certainly should not be done in the setting of spondylolisthesis. So this is the rub. You don't necessarily need a A-lift, which is going in through the belly. That's a sort of a bigger operation, but most of the time, and again, I don't know your exact situation, and there are some times when it slips just a teeny bit, and we get everybody to talk about it, and we agree to ignore the heck out of it because we want to do a smaller operation. But the size of the slip matters, and if it slips a lot, it's not responsible to do a laminectomy without a fusion because you're gonna get burned on that. If it slips a little bit, sometimes there's leeway to do something that's less invasive and keep our fingers crossed and hope it doesn't turn in, that we don't make a bigger problem than you started with. A single-sided problem, single-sided pain, which you don't have, but single-sided pain, there may be a role for minimally invasive decompressions alone because you disrupt the stability of the spine less. Again, unfortunately, those things are really kind of like situation specific, and I would have a hard time like putting my nickel down without having a little bit more information about your back. I've tried anti-inflammatory drugs and acupuncture with no success. I still have numbness in my legs and butt. I already have a laminectomy from C2-3, and this is cervical infusion, C5-6 from an unrelated accident. Do you have any other suggestions? So numbness in my legs and butt. So, um, numbness is really difficult. Anti-inflammatory medications typically does not help numbness. Acupuncture, maybe. I wouldn't write that off, but you've tried it, it didn't help. Um, we don't, if it's a burning numbness, and I'm sort of like twisting your words a little bit, but something that's uncomfortable, then we maybe would get away from calling it numbness and calling it more along the lines of some type of pain. That's a situation where the nerve pain medications, Lyrica or gabapentin, might work. Neurontin might work. Um, if it is pure numbness, we don't have a lot of treatments for that, and surgery sometimes will help that, but also that symptom has a higher rate of not getting better after surgery. Okay. I have sciatica in the back of the right leg. I've had this for a while. I'm going another injection in 2 weeks. Go to the gym 3 times a week and physical therapy. My right leg underneath my buttocks gives out on me often. Um, I also have MS. If the second shot does not help, what more would you suggest? So I mean, if your leg is giving out on you and like knees buckling, that's a sign of sort of more progressive spinal stenosis. Now, again, this is the second person who talked about MS. One of the difficult things about MS, not so much as far as the pain, because that's not a real common feature of MS, but people who have loss of function of muscles, sometimes that's a feature of MS. And so it would be very important to get in front of somebody who really knows what they're doing, look at your MRI, see if the location of the compression of the nerves and what nerve roots are involved are ones that would be likely to cause knee buckling. Because if that doesn't match up with what's going on in your back, it's possible, but that the weakness is more about the MS than it is about the sciatica. Um, it sounds like you've been sort of around the block on this thing. Um, like I think it's kind of the same answer is that steroids haven't worked. Um, the doing the PT, maybe the answer would be trying the nerve pain medications, anti-inflammatory medications, those things. But the issue is a lot of times there's not like that many treatments out there, right? That wasn't like a 35 or 40 bullet point list. There's steroids, can't take all the time, steroid injections, nerve pain medications, anti-inflammatory medications, and then sort of like the acupuncture, chiropractic. And then once you get through that, if you have a structural problem in your spine, pinching the nerve, and none of those things work, you either get it fixed or you live with it. And that's unfortunately sometimes is the difficult decision. It doesn't always go away, and it's not always treated through successfully with non-surgical methods. I recently had a lumbar epidural injections. How long till I have minimal less pain? If it doesn't work in 7 days, I don't think it works. Do you perform any procedures with stem cells? Specifically, no. So I am, I think one of two. I run a basic science lab in Center City at Jefferson that for a pretty long period of time was studying stem cells, and we actually are putting together a research project that we completed looking at whether stem cells can help rescue disc cells. Don't waste your money on stem cells. Okay, there's no evidence it works. There's none. And there's people who do stem cell injections. There's a reason it happens for cash, is because it's not FDA approved, it's not regulated. No insurance company is going to pay for it. Medicare, which doesn't, it doesn't have a lot of rules often on what you can bill for, doesn't pay for it. So I don't perform procedures, and I would say for the treatment of spinal disease, particularly spinal stenosis, save your money. Mild treatment, I've never seen someone that it works on. Now that's biased, because if they get it and it works, they wouldn't come see me, right? So take that with a little bit of grain of salt. But I've seen Miles perform before, and it's knowing, having done probably 5,000 spinal decompressions in the low back, and you see how much of the overgrown ligament and bone spur and how deep you have to get in to take that out. It's hard to imagine doing much with a mild, just because of it's a blind procedure. You're just looking at an X-ray machine, hoping that the little thing you're putting in there to chew up the overgrown ligament doesn't get into the nerves. Um, it used to be said back surgery begets back surgery begets back surgery. That is true. That statement only is in relationship to lumbar fusion. There's nothing about a laminectomy that destabilizes the level It doesn't change the wear properties, and it doesn't change the way it moves. So a lumbar laminectomy should have no bearing on the aging of your spine. Now, people who get it in the first place have a genetic predisposition to get it, and you still got those genes in every cell in your body. And so people who get it and then have multiple surgeries probably is more likely, because they have a genetic predisposition, that the surgery caused that, particularly for the topic of this discussion. Now, the relationship between lumbar fusion surgery and a problem above and below is an extremely complicated one. That relationship is certainly not proven. That is still a theory, and it sort of goes along the same lines. Like, people, you're looking at a biased group of people who had it in the first place because they had genes that led them to get it. A person's susceptibility to get disc problems and spinal stenosis on a population level, meaning when you look at thousands and thousands of people, it's probably 75% genetic. Um, that said, it's the adjacent level problems is an appealing theory, and like there's some parts of it that strike me as particularly intuitive, but that's not something that has to do with this discussion because we're not talking about fusion. What Rothman and PA does acupuncture? Salome Sharma, Sharma. She's great. How about back pain mostly and radiculopathy occasionally? Will you operate? Usually no. But it gets back to what I said before. If you have a spinal stenosis, you have pain down the leg, and for you, it'd be worth it to have an operation if the only thing that got better is the butt and the legs, then of course you would do it. Because at the end of the day, like, there isn't anybody, no spine surgeons, no non-surgical spine surgeons can really evaluate the quality of someone's life and the loss of quality of your life that comes with the buttock and leg pain. And so that's something that's so individual, and why there isn't, like, some of this stuff doesn't have a formula. This is about, like, getting to know someone, seeing, what their MRI looks like, what their symptoms are, how debilitating it is, and then making a decision it's just really a quality of life decision together based on, the best guess that I can give them about what the outcome is going to be of an operation. Is ablation a procedure that treats Is ablation a procedure that treats certain types of stenosis? No, it doesn't treat stenosis. It's for back pain from arthritis, not for stenosis. My pain is only in the buttocks. It can be, yeah. So in that sense, so buttock pain, the question was, is buttock pain from stenosis? Very often it is. A lot of times in that setting, you look for the pattern of it. For instance, buttock pain that reliably comes with standing or walking improved by sitting down is probably a form of radiculopathy associated with spinal stenosis that just for you happens primarily in the buttocks. There's other things you can do to get closer to the truth sometimes, like, for instance, if you get an epidural injection, which is only supposed to help leg pain, and temporarily the buttock pain eases or goes away and then comes back, and you have spinal stenosis that's bad enough that we would believe it could cause pain down the legs, then you probably get the same benefit as someone who gets it that goes all the way down to their foot. I have L4, 5, S1 fuse with Harrington rods. I'm 67 years old, have a lot of back pain with diagnosis spinal stenosis. So spinal stenosis and back pain we got to disentangle those two. It's not the same thing. Now, someone who has Harrington rods, really have to look and see. Harrington rods, one of the consequences of that, which was, at the time, it was all sort of that they had to fuse vertebrae together, definitely has a footprint on the levels above where the surgery ended. And so, that it could be that you're pitched forward. It could be that you have severe degenerative changes above it. There also always is the prospect of it not having fused, although that was a long time ago. So you probably would have figured it out at some point if that didn't heal successfully. If it's back pain, mostly the spinal stenosis is less important. But in someone who has a history of Harrington rods, and given what we know about him, you should be evaluated with standing upright films to look at the overall alignment of your spine. This may be an alignment problem. Does laminectomy create a need for fusion? Should never. If the laminectomy is done too wide and you take too much of the structure of the vertebra away, that can create a situation where you develop instability from the fusion, but a well-done laminectomy does not. How do you feel about ablations? I feel good. I mean, I don't do them, but I think in the right setting for the treatment of back pain, not stenosis, they're useful. 22 years ago, I had L5 laminectomy. Now I have recurring pain and was diagnosed with L4-5, L5S1 instability. Fusion is the only medical intervention recommended. Physical therapy is help, but the leg pain comes back almost every night. Before the laminectomy, I got some short-term release by traction. No one will do that anymore. Yeah, I mean, traction, that's not true. So a chiropractor will do traction. They do it often now with like it's kind of like this table you lay on, and it's like a stretching rack kind of a little bit. But the presence, the severity of leg pain is an indication that isn't just about instability. If you have instability L4-5, L5S1, and you need another operation, you probably would need a fusion. But if you have spinal stenosis, meaning nerves pinched and a substantial component of leg pain, surgery could help you. If you have interest, though, I would seek out a chiropractor that does traction because the physical therapist may not do it anymore, but chiropractor very commonly will. Is it common to have only pain in the buttocks on one side? Yeah, we talked about that a little bit ago. L5 or S1 nerves go to the buttock. If you have it only pinched on one side, that could give you one side symptoms. It's not uncommon though for people to have central stenosis, meaning it's symmetric pressure on the nerves and only one side hurts you. I think if it follows a pattern, like I said before, of spinal stenosis, you may, have a good chance of getting rid of that, even if it's only in the butt. I have spinal fusion with 2 rods put in my low back. I still have back pain. Tried physical therapy and take medications for pain. What else can I do? First, every time, whether I did the first surgery or someone else did the first surgery, someone with persistent back pain after spinal fusion, if you haven't had it, you need a CAT scan once you're a year out from the operation, at least, to make sure that it healed. Sometimes even with the x-rays looking pretty good, those screws can wiggle loose in the bone and, your spine's still moving in an abnormal way with the screws banging around the inside of those screw tracks. So that's the first thing. Um, I think, unfortunately, I think like going down the low back pain pathway is like a little bit off the beaten track, and it would rely on a lot of information that I haven't really talked about tonight. So I don't think I want to get into that, but I would get in front of somebody, get a CAT scan, make sure that it didn't not heal. Hope I have an appointment with you in Marlton on Tuesday, and hope I can get some relief. Searching for the MRI from Jefferson. I hope you can get some relief too. If you can't find it, though, don't sweat it. Jefferson has really great online access. We can pull that up in like 5 minutes. So, rest easy there. I wouldn't spend too much time looking for it, and certainly don't go like get a new one burn or anything like that. Just show up, say you don't have it, we can get it. So, I also have sciatica on the left from my buttock to my knee. Shoot, that's from somebody who wrote above. Let me look up. Okay, hold on. Backwards. So options. Um, okay, sorry, I'm going back down. So for the Harrington rod person, um, yeah, I mean, like, so again, if the answer is there's nothing structurally wrong with your spine and it's fused the way it should have, and it's just a generation, whatever, again, back pain surgery is not super successful. If the Harrington rod's tilted you forward and you're pitched forward and you can change the alignment with the surgery, sometimes that helps the back pain. The sciatica, if there's a nerve, if you have spinal stenosis and you have sciatica or pain down the butt and the leg, almost always will get better with an operation. Otherwise, you go through that list, epidural injections, nerve pain medications, things like that. Radiofrequency ablation, I think I already answered that after that was put in. How long can you stay on NSAIDs, anti-inflammatory medications like meloxicam or Celebrex before it hurts your kidneys? Some people can be on it forever. That is something that if you're going to be on it consistently for a period of time, you have to keep checking kidney function at first every 3 months and every 6 months. The second that those numbers dip, you got to get off them. That doesn't always happen to people. My dad had real bad shoulder arthritis, took a leave forever, and never got into any trouble. And so that unfortunately there's no pat answer for that. Scott, oh, you're looking at Dr. Kepler with 2 Ps. I think that's somebody else. Dr. Kepler operated my back about 4 years ago, and it's been great. If I find the guy with 2 Ps in his name, I'll tell him you're doing really good. I'm just kidding. I'm just kidding. Thanks for writing that. Surgery moved to Arizona. So there's someone who I did an operation on 2019. They've subsequently moved and has back pain when bedding squatted. So again, same thing. First thing to do, whether it's me or somebody else, is get a CAT scan, make sure that everything healed the way it should have. If that looks fine, then you know those levels are not involved, and then you're looking for either severe arthritic degenerative changes or sort of like a deformity, like a change in the shape of your spine, which could lead to overburdening your muscles. Again, that's a little bit down a different pathway. If you need some referrals for someone in Arizona, give me a call, give the office a call, and we'll reach back out. That's not a problem at all. Um, what happens if someone had a laminectomy already? Now, arthritic vertebra, but has prolonged numbness in the lower legs and feet and cannot walk for over a month. Had an epidural injection. It's still hard to walk. Um, there is nothing that injects to release compressed vertebra. It's this. So the two things here. Number one, numbness is a difficult symptom to treat often because it's not responsive to a lot of the non-surgical treatments that we have. If the nerves are pinched, it can cause numbness, and if there's a really bad structural problem, there may not be an answer for numbness except for an operation. But unfortunately, it comes with not the highest rate of success. Um, what steps to follow before surgical procedure? So the slides will be
Yeah.
shared with that list of things to do, and that's not necessarily like a linear progression, like you go from the top to the bottom. It kind of depends on people's health, ability to take steroids, what their interest in is or their apprehension is about having injections. But that list will be sent out. Have degenerative disc disease, spondylolisthesis, and spinal stenosis, also bulging disc. Issue is mostly the back. Difficult problem, but spondylolisthesis, the treatment of spondylolisthesis with spinal fusion has a success rate for getting rid of back pain that's like, I usually tell people like 60%. That's not that good. For back pain, again, a little bit of a different discussion, but go down the path of injections, radiofrequency ablation, anti-inflammatory medications, physical therapy before you get surgery to treat low back pain with fusion because it doesn't always work. Why do physiatrists give steroid injections in the gluteus muscle instead of the epidural to L3, L4 levels for spinal stenosis, burning, and pain to the thigh, groin, and knee? So that an injection into the buttock is not an epidural. Sometimes people like want to say that they're going to get like a piriformis injection, which is this muscle that goes over the sciatic nerve, and like I've never seen actually someone that has it convincingly in my entire life, but try to do injections there. I don't know why people do that. I don't think it works. I think you should get a regular epidural, which in the needle goes into the back itself. Been diagnosed with stenosis and synovial cyst. The stenosis can come from a synovial cyst. I didn't cover that because it's not a real common cause of it, but it's basically a response to arthritis in the joints that connect the vertebrae instead of like a bone spur coming off the joint. A cyst comes with which is a fluid-filled sac. In those people, you usually would try epidural injections. You also see if one of the physiatrists, the non-op docs, can get a needle into that joint, and sometimes they can suck the fluid out. Now, it often recurs, but it's a unique treatment option for people with that condition. Neurosurgeon versus orthospine surgeon. Definitely orthospine surgeon. No, just kidding. So there are good neurosurgeons, there are good orthopedic surgeons, and there's bad ones of both. What you need is someone who does spine surgery only. You don't want someone who's doing spine surgery in some knees and hips, and you don't want someone who's doing spine surgery and some brain surgery, because what we know from orthopedics and from every other surgical specialty, the best people do the most. And so that's why I would say that not because we're orthopedic spine surgeons or because, other people are neurosurgeons. The reason I think that Rothman Orthopaedics is best in this area is our surgical volumes are through the roof compared to everybody else. And so like from the standpoint of the patient, you can use that as a pretty successful in something that's been looked at over and over, a pretty successful proxy for people who know what they're doing because they have so much experience doing the same things. But a neurosurgeon who has as much experience as me potentially could be as good. All right, let's see. I have stenosis at L3 and 5, being currently treated with gabapentin. The issue I still experience when I stretch, I experience severe muscle cramping in my calves or hamstring. In general, we don't think that spinal stenosis causes that. It can by way of weakness, because weakness creates a susceptibility to cramping, but we don't think typically the irritability and the nerves caused by spinal stenosis causes that. It may be stretching and weight training, I think, would be more likely to be something, the way to treat that than to treating spinal stenosis. There is spinal stenosis may very well be a red herring. Okay, so I pinching on my nerves that's progressed to the ability where I can't rise on my toes. So like that means the gastric soleus or the calf muscle is weak, which affects the ability to walk. It's vertebra shifted, so a spondylolisthesis, been in spinal decompression for 6 months. I assume that means like with a chiropractor. Not a lot of pain. I want to walk normally again. There's almost no treatment for that except for surgery. And the reason is because you have a structural problem, which is slowly or not slowly taking the ability of your muscles to do their job. You have that condition has a very limited window to get the problem fixed, or there's not especially without pain, you're going to be stuck there. And so, I would get in front of someone, forget for now about the spinal decompression, get in front of a surgeon with us or somebody else to look at your MRI or to order an MRI and figure out if you have compression of the S1 nerves, which is what causes calf weakness. If you do, you got to get that thing fixed, or this is not going to get better. Okay. I had a laminectomy L2 to 4 and some sort of growth on L5. I initially thought it would require hip replacement, I think. During the time waiting for surgery, 5 months, the stenosis progressed so much I developed foot drop. Okay, 14 months after surgery, I still have foot drop. Severe pain in my left calf to tip of my toes. So that's tough. The foot drop, the weakness. So of all the symptoms, that the likelihood of symptoms to get better after surgery have a hierarchy to them. And when you develop severe weakness, sometimes it doesn't get better. It says that you're 14. You developed it I can't tell if you've had it for 14 months or if you developed it 14 months after. If you've had it for less than 5 or 6 months, there still is a reasonable chance of getting stronger, but you need to get some imaging which shows whether or not the L4 or L5 nerves are still compressed, or had some sort of recurrent process which led to them being compressed. What is the connection between spinal stenosis and peripheral neuropathy? True peripheral neuropathy, no connection whatsoever. So neuropathy can't come from stenosis, but the symptoms can overlap. So in really extreme cases, people with neuropathy can get weak in the legs. People with spinal stenosis can get weak in the legs. People with the hallmark of neuropathy is numbness. Sometimes it's uncomfortable. Sometimes it's just pure numbness in the legs, and it's a unique pattern. It's like putting a stocking on, whereas it's numb all the way around your leg up to a certain level. That's not the way that spinal stenosis symptoms usually develop. Usually that's more in like strips of skin, like the front of your lower leg hurts or the back of your leg is numb, or not all the way around. So there may be some interplay there, but the answer to the main question, spinal stenosis and peripheral neuropathy have nothing to do with each other. I've heard this. Is there anything new that's minimally invasive, i.e. just scraping around the impinged nerve? I mean, there is, but as long as you don't have instability. Aside from some people who have instability and have single-sided symptom where you can like kind of sneak in and not disrupt the stability of the spine, there is nothing, sort of like brand new that has allowed us to circumvent the need for spinal fusion in people with instability who need to have problems on both sides addressed. Patient see orthopedic or neurosurgeon? Orthopedic surgeon. I have a spinal fusion 11 years ago from L3 to 5 for pain in the butt and down the legs. Over the last couple of years, the pain is back, but now more in the calf and the foot, losing some strength in my foot. Have arthritis in all my back. I have had a EWC, maybe it's like an epidural or something. I don't know what that means. I mean, it can come back. It depends on if it's fused, or you can continue to develop degenerative changes elsewhere that can cause similar symptoms. So it sounds like that person's been a years long. They have bad leg pain. In general, we win with leg pain. So people who have leg pain, you should be very optimistic that you can be helped and you don't have to live with that. Again, like I said before, our track record is much more checkered in the treatment of low back pain. How about stem cell? Stay away. No, it cannot help nerves, it cannot help spinal cord. There's no evidence in the history of medicine that either of those things is true. There's like some, if you go on Google and search stem cells, spinal cord, there's like some videos there's a big cottage industry in China where they get where like Chinese physicians will bring people either from China or from other countries there because it's not really regulated, injects stem cells into the spinal cord. And then there's like a couple of videos of people like seemingly walked after it. I, it's sort of unsubstantiated. It would be weird if that kind of thing would only work in one part of the world and not elsewhere. There's not any evidence that's solid at all that stem cells can help nerves in the periphery of the body. Certainly not in the central nervous system, where humans have a very, very limited ability to recover function. With the exercise program that strengthens the core abdominal muscles be helpful? Absolutely. Least risky, most successful treatment for low back pain. What are chiropractic if you have a fusion from L2 to L5? There's no reason you can't see a chiropractor. Some chiropractors may be a little skittish about doing it, but there's nothing in the low back that could be screwed up, through manipulation or decompression or like stretching decompression or something like that. I think it's a follow-up. Had a recent epidural injection. Really don't want surgery again. Hope I get some relief. I mean, the good news, like no one has ever died of leg pain, and I don't mean that to be like glib about it. It means that like if you can live with it and you're more scared of having an operation than you are of living with the pain, stay away. Especially in light of what we talked about before, which is that by and large people do not develop bowel and bladder problems. By and large people do not develop leg weakness that's so debilitating that it takes away your ability to walk. You may have to modify your activity, things like that. But in general, if you can gut it out, gut it out, and try to find someone who can help you with particularly medication strategies if the injections aren't working that can ease the pain. It may not save the day, but it can make things better off than they are. 2 sets of lidocaine injections. First was successful, second was not. Sounds like it's in the evaluation for radiofrequency ablation. There should not be a length of time that you have to wait before you can do it again. I would do it again and get that third one as a tiebreaker. Moderately severe central stenosis at L3-4 with foraminal narrowing. 4-5 has sounds like mild stenosis. I had an ablation last year with no relief. That's only for back pain. I got worse in June. I'm still unable to walk much. An epidural with not much relief and scheduled for another. I started chiropractic treatment, but concerned with being cracked. Could it damage the irritated nerve? No, it won't do. It may not help, but it won't hurt you. I've also tried decompression treatment. Is this worth continuing? If it didn't help you when you did it, no. I wouldn't waste don't waste your time there. I mean, it sounds like you've kind of leg pain that comes from spinal stenosis. You're running pretty quick through all the things. If you don't have a shift between the vertebra, this is a situation where sometimes, a small surgery gets you through this thing. L3-4 sounds like the main level. Again, I haven't seen your MRI, but it's for the treatment of button leg pain in someone who has spinal stenosis without instability. It's a sweet spot in the spine world. It's a small operation with a quick recovery that works almost every time. So, I think some of the things I wouldn't be worried about a chiropractor, but if you can't walk, it sounds like you need to get that thing fixed. Slower. This is a follow-up on spondylolisthesis, meaning a shift between the vertebra and spinal stenosis. She was nervous about getting a surgery. I mean, I get that. You should be nervous about it. That is a part of it. The reality is that sometimes you get to the point where like that's the only option left versus just living it with it. And it again though, but if you have a big component of back and leg pain, it's a very successful surgery. The lumbar fusion, it does add a level of complexity, but like on a made up scale of 1 to 10 of surgeries that I do, a laminectomy or a discectomy is like 1 or 1.5. A lumbar fusion is still like 3. This is not like one of the huge big operations that I'll tell you, let's hold off on. It's a successful surgery, that we do often. You just got to pick the right times to do it. And someone who, does isn't doing it purely for back pain will often win. Why does small dose Flexeril help pain on gabapentin, as well as 600 milligrams going to bed, 200 GABA in the AM? Um, I mean, probably it's treating different problems. So it may be very well that the Flexeril is treating your muscular back pain, and the gabapentins, treating leg pain, but also making you sleepy. That's one of the nice side effects sometimes of gabapentin, particularly when it's used before bed. It can help you sleep. To understand that you do not recommend rods in your back. I mean, that's true for the treatment of back pain. Very rarely. Out of 600 operations last year, I did one for the treatment of chronic low back pain. All the rest are for instability or pain down the legs. There are situations where people have both instability, shift between the vertebra, and spinal stenosis, and their butt and the back pain is making them miserable. And there's not a way to treat that without rods in your back. But we're only doing that as a preventative manner, in a preventive manner, to stop the shift from getting worse. The success of those surgeries is going to be driven by the ability to relieve the pressure on the nerves and the relief of people's leg pain, which is a high likelihood of success. So it's severe pain in my right side hamstring. I don't know what that's from. Sorry, I tapped return. So yeah, so okay, I see. Back up to the rods one. For compressed discs, yes, for low back pain with degenerative changes and disc collapse, I recommend against it typically. For the person on gabapentin and Celebrex with the left leg buckling, and you can still get sharp pain in the left leg. I mean, it sounds like you're not taking a huge dose, but you're taking a decent dose. It sounds like it's not working. You either go up on that, but again, there's no treatment for weakness except for an operation. So if you get to the point where like the leg weakness is a problem, you can't trust your leg, you're worried you're going to fall on the steps or whatever, that is something where you need to consider very seriously if you have the right MRI that suggests a source for it, fixing it, because there's a window to fix weakness, and if you get beyond that, you're sort of stuck with it. And quadricep weakness with your knee buckling is extremely debilitating. If you have a foot drop, honestly, it's not as big a deal. You get a brace, you can walk pretty normally. You can't brace your knee because then you can't bend it enough to like go up stairs and things like that. All right, low back pain, osteo and spinal stenosis. What you suggest? Physical therapy, anti-inflammatory medications. If those don't work, see a non-surgical spine doctor to see if they would consider injections to treat back pain. Would a laminectomy help me, the person on gabapentin with the knee buckling? Yeah, maybe. I mean, if your MRI shows that the nerves are pinched, you have pain on the leg and your knees buckling, my recommendation, without knowing anything, so like obviously this you take with a grain of salt though, but in that setting with leg weakness from stenosis, yes, it probably would help you and stop it from getting worse. Is the only hope you have to get the strength back. But if it's causing the leg pain, you're looking at a 90+% chance of success. What is the best approach to treat left leg pain? So that's a hard one to answer because there's a lot. The anonymous attendees is a name for a bunch of different people, and so I can't connect that with the initial comment. When I have pain in some of my hips, hip pain is typically, if it's on the outside, like where the pockets of your jeans are, that usually is from the spine. Someone who had a fusion in 2002 told they need an MRI. Can you have one? Absolutely. You can have one 1 minute after screws are put into your back. There's no contraindication. The metal doesn't pose a risk at all. If you had a surgery a long, long time ago, 2002 would be borderline. The metal back then was either stainless steel or cobalt chrome. Sometimes those cast big shadows on an MRI, and you may not be able to see a lot, but you can certainly get it. Can one play pickleball or tennis after back surgery? Definitely. You can start 6 weeks in. Can the use of an inversion table be of any assistance? For back pain, yeah, I always tell people try it. If you get off that thing feeling better than you started and it lasts a little bit, it's not going to do any harm. Pain at the iliac crest and outer thigh, numbness down the leg, injections help for 2 weeks max. MRI shows bulging disc and stenosis help. If everything fails and you have stenosis pinching the nerves, no instability, sweet spot. Laminectomy, 90% chance of getting rid of the pain down the leg. And the stenosis, I think you mean congenital. That means it's not genetic. I mean, they're kind of similar in general parlance, but in the spine world, you talk about congenital stenosis. What that means is you have a small spinal canal to begin with. That is something that responds very well often to laminectomy. Um, the 2002 fusion, now the update is done at Rothman Institute. They still had this in 2002 or in the 90s. They still had the same MRI non-compatible metal everybody else did. But you just got to get in and get an MRI off, or we can pull the op notes, see who did it, and what it is. And if we look up the system, sometimes you can get a sense of it. Although there wasn't some overlapping period in the 90s and early 2000s where different companies made the same systems with different metals. So you'd have to figure it out. Looks like this is mostly people signing up. When I get up from sleep in the morning, it's very hard to get out of bed. Is there any way to help this? If it's back pain, it's sort of stretching, striking. Sometimes I have people like put ibuprofen by the bed, set their alarm for 3 a.m., get up, take it. You barely know you took it, and you may feel better in the morning. Spinal stenosis symptoms in the morning is when you first wake up, it's common for that to be pretty bad. I don't know. I mean, again, maybe dosing of a nerve pain medication during the night or before you go to bed or in the middle of the night may help. Sometimes strategies like that, but there's nothing about the timing in the morning versus the night that there's specific treatments for or something like that. Can severe stenosis cause problems walking up and down steps? I seem to have weakness as opposed to pain. Absolutely. L4 is one of the three nerves that goes to the quadricep, which helps to propel you up the steps when you're extending your knee. That could definitely do it. Um, do you know Dr. Caleb Barron from Ortho, Arizona, who worked at Rothman in the past? I do know him. He is a capable spine surgeon. Do you recommend a massage therapist, particularly in New Jersey? Um, Not off the top of my head, so there is one of the medical assistants that we work with. It's also a massage therapist, but I never like got permission for her, and there may be some weird conflict of interest in me plugging her. So she doesn't work. She doesn't do massage therapy under Rothman, but there are plenty of people out there. If you come in the office, and I can tell you in person, but I don't want to say it out loud in public format.
She can email and we'll get it to her if she needs it.
Okay, perfect. That's great. She's great. My physician assistant went to her. I think like that. It would be a good person to see. Um, I have to drop off. 14 months. You've mentioned physical therapy. I've been going to physical therapy for stenosis in the legs. Yes. So the question is, does physical therapy help leg pain from stenosis? I don't think so. It's unfortunate that insurance companies use physical therapy as a gateway for a lot of other treatments, and sometimes even for getting MRIs. There's no evidence it helps leg pain. None. It treats back pain. And those people, a lot of times it's the same person that has both, but it really is that's misguided on behalf of insurance companies, and it's like probably not misguided, it's probably on purpose because they're using it as a hoop for you to jump through before that you can actually start treating yourself. I had surgery on L4, L5, I think in S1, developed numbness in both feet, mainly my toes and balls of my feet. Is there anything I can do to help with numbness? If it's painful, the nerve pain medications, if it's pure numbness, meaning the lack of sensation, there isn't a lot of treatment for that. It also, the pattern also sounds a little bit like it may be the beginning onset of neuropathy, which is where the nerves in the legs just kind of go a little haywire and isn't directly related to the spine. What do I think about implanted nerve stimulation? Like a spinal cord stimulator is, usually sort of like a last resort type treatment, but for people who have unexplained nerve pain or have severe unremitting debilitating back pain, and they've sort of been around the block, there is a percentage of people that those things help. No one does that at Rothman Institute. It's done by usually the final product is usually done by neurosurgeons. The trials, the first stage can be done by non-surgical spine docs because that's a procedure, not a surgery. I'm pretty sure Allison Axelrod, Axelrod, which one of the non-surgical spine docs in New Jersey and Rothman does the first step. The second step, I sent everybody to Chen, Chen Wu, who's a neurosurgeon at Jefferson, great guy. And he's also a straight shooter, so he will tell you if he thinks you're a good candidate for it. Chen Wu. Another question about stems.
Mm.
I have spinal stenosis. I don't have leg pain. So if you have weakness, you still may derive a benefit from being treated for that. Although it's less common to have weakness without pain. Doesn't mean it doesn't happen, but it's less common. You just got to be thorough in making sure there's not something else you're missing. Um, can you get cervical stenosis? Absolutely. It causes numbness and tingling in the upper extremities. Absolutely. Can it be treated if this is cervical stenosis? Definitely. That would be something that, because some symptoms from that come from spinal cord compression, it'd be worth coming in and being evaluated and getting an MRI, because that sometimes is an issue that can't wait, or is a little bit more urgent. Is spinal stenosis considered a disability? Sure, if it stops your ability to walk a distance, people get uh, disability plates and stuff like that from that. Ibuprofen. What's your recommendation for ibuprofen dosage? I'm not touching that. You got to talk to your family doctor. There's too much rolled into that. That has to do with other medications, other medical problems. What your kidneys are like. Do you have a history of diabetes? All sorts of things that is more of a discussion than we should do here. And it's also like not my specialty. Can spinal surgery be done under spinal anesthesia? Yes and no. I've tried a couple times with older anesthesiologists because they know how to do it, because it used to be more of a common thing in the United States. At Jefferson to do it, in general, they're not that excited about it, because you have a patient face down who you don't have control of their airway. So if they start having difficulty breathing, it's a real problem. But the answer is yes, it's just not common. There's some people advocating it, sort of anew, like, what's old is new again. But it's very, very rare. The answer is that it can be done. You mentioned Lyric. Do you think it's better than gabapentin? Um, I'm on 300 3 times a day. What dosage of Lyric would be comparable? I think that's like the comparable dosage would be like 75 twice a day. I think the answer to that is not necessarily, but maybe. And what it is not that I think I have a strong feeling one way or the other. I've seen so many times when people did not have a good response to one and the other one worked well. So I think you got to give it a college try. If you are on a reasonable dose, which you are, you could go up a little bit for another month or so. But if you've been on it a couple months, is not doing anything or not doing much, I would slowly, you have to wean off the gabapentin and try Lyrica, because you may be someone that the other one works for. That's it. Bottom of the list.
Well, just Dr. Kepler, thank you so much. And you went through every question. And just as one of our attendees said, we really appreciate your presentation, your patience, and your willingness to try to help people, even though you never saw them. So that's why we do these, everybody. We thank you for joining us. Dr. Kepler, we thank you so much for all of your time tonight. And if anybody has any questions, you all have my email. I will be happy to get it to Dr. Kepler. If you need help with an appointment, you can email me as well. So everyone, thank you for your time, and everyone have a great holiday season.
All right. Thanks so much.